Okay. My name's Cemil Browne. I've been with Intelerad for about a year now. I am the general manager for Australia and New Zealand, and I'm really excited to talk about something that's happening in Australia, the National Lung Cancer Screening Program. We're going to get into some details there, but I'm pretty excited to be here with some astute guests to talk about it. I might hand it over to Dr. Jones next to me to introduce herself and then go around the corner.
Thanks, Cemil. My name is Catherine Jones. I'm a cardiothoracic radiologist based in Brisbane. I work in public and private practice. Over the last 2.5 years, I've also been one of the radiologists helping to design and now implement the National Lung Cancer Screening Program in Australia. So that's been a lot of work, as you can imagine, but very satisfying. And I'm looking forward to going into today about how it's going now that we've actually started.
Hello, everyone. I am Dr. Sarang Ingole. I am the vascular and intervention radiologist, and I am currently serving as Chief Medical Officer at CARPL. I basically look after all the clinical operation, and I've been closely working with our folks at Australia, especially with the National Lung Cancer Screening Program. I'm excited for today's discussion. Thank you.
Hello, my name is Chris Chapman. I'm the Chief Information Officer at Perth Radiological Clinic, based in Perth, Western Australia. Clinic, we're actually 24 clinics, so soon to be, primarily focused around the Perth metro area, but also going to have first regional one too. So doctor owned and led practice, been around for a long time, about 1,300 people, and looking forward to discussion today.
We might just start with an easy question across to you, Chris. Tell us a little bit about Perth and where it is for those people who don't know.
Thanks, Cemil. So Perth is in Western Australia, and it is the most isolated city in the world, essentially really surrounded by desert, basically. Got to go a long, long way before you get to another major city within Australia. Very beautiful part of the world, and I'm very lucky to live and work there. Originally from Manchester, very cold and wet, not as cold as Chicago, but Perth is definitely not like that. But a lovely part of the world. And a fun fact, which I learned yesterday from our sonography manager, Ben Roberts, is that Western Australia is 4 times the size of Texas. So there you go.
You don't want to say that too loudly around here. I think that's how you get into real trouble. Okay, I was going to introduce the National Lung Cancer Screening Program, but I think that's silly when we have one of the designers of it next to me. So I might hand over to Dr. Jones to introduce the program and its aims for us, please.
Thanks, Cemil. So the National Lung Cancer Screening Program in Australia uses low-dose CT to identify people who are at risk of lung cancer based on their cigarette smoking history, to screen them on a 2-yearly cycle. And eligibility for the program includes people aged between 50 and 70 years inclusive, who've had at least 30 pack years of smoking, and who are either still currently smoking or have ceased smoking in the last 10 years. And we estimate that across Australia, there are about 1 million people who would meet eligibility criteria. It's hard, of course, to know this for sure, but we estimate about 1 million. The program has 3 goals. The first goal is to reduce mortality from lung cancer, because lung cancer, although it is the 5th most commonly diagnosed cancer in Australia, is by far the most deadly. So the first aim is to reduce mortality. The second aim is to enable access to smoking cessation for those people who are still smoking who would like to consider, those activities. And the third aim is to try to bridge the gap in healthcare outcomes when it comes to lung cancer for our most vulnerable populations. And that's people who are Aboriginal and Torres Strait Islanders, so our Indigenous population, and people who live in regional and remote areas of Australia, because we know for many reasons that they tend to present even later than people who live in the cities, and that their outcomes are a lot poorer. And so they're the 3 main goals of the program. I might just quickly mention as well that when you have the low-dose CT, it's a non-contrast study, and that it is being read to a bespoke nodule management protocol that's been developed, by the Australian and New Zealand Society of Thoracic Radiology and the Thoracic Society of Australia and New Zealand, so that we have the most appropriate nodule management protocol for us in Australia for our 2-year cycle. So that's it in a nutshell.
Perfect. Thank you so much. And 1 million studies a year is a lot of additional load on the health system at the end of the day, right? That's 2 or 3% increase in private studies done across Australia, roughly speaking. Rough math would tell me. I might just ask Chris, how are you thinking about that from a systems point of view out in WA? That's a lot of additional demand that you need to meet. How are you thinking about it?
Yeah, thanks, Cemil. Yeah, it's certainly an interesting one. I'm relatively new to radiology, and I've never worked in a business before where demand outstrips supply considerably. So we're a very busy practice. Care about quality and obviously care about patients off the back of that. So in terms of Western Australia and dealing with that extra volume, I think it's tough. I'm not sure if it's still the case now, but I don't think the public system is doing much screening right now, if any. And so it's private practice that needs to pick up that shortfall. Absolutely, though, as a business, take it very seriously and try to open up more and more slots and get more and more patients in. I think more broadly in Western Australia, given the size of the state, the geographic spread and the spread of that population, I can imagine it'd be very tough for regional patients to actually get that care and get access to that program, as Dr. John just touched on, in terms of regional opportunities, the regional patients not presenting in that particular way. But certainly from a Perth metro area where our clinics do open, and our latest one in Bunbury, our regional one in February 2026, hopefully there are a lot more opportunities to serve a broader proportion of the state.
Thank you. And Dr. Sarang, I might hand it over to you. When you think about this program at a global level, what else are you seeing around the world that looks like this, and how are other jurisdictions meeting the challenges that Dr. Jones just talked about?
So most of the other geographies have these programs, which is usually an annual screening program. And the program are usually designed along the lung RADS categories. Whereas in Australian program, it's one biennial, and they have incorporated a PanCan risk scoring for the baseline. I think that was a good decision in stratifying those patients right at the baseline, so that we don't miss because since it's biennial in nature, you don't miss the cancers which are for the long-term follow-ups. So that was a basic difference between the programs worldwide and the national cancer screening at Australia.
Okay, thank you. And to the subject of AI, as one of the designers of the program, how did you initially envision AI helping support the rollout?
So I guess the thing to say at the beginning is AI is not mandatory in the program, but it's strongly recommended. And there are several reasons for this. The first is, as you say, 1 million potential extra scans per year. I mean, that's a crazy number of CT scans to report. We do not anticipate anywhere near that many coming through the door, simply because we know, particularly as in the early stages of any screening program, there's going to be a relatively slow uptake. But we've already done nearly 40,000 CTs in the first 4 months, and this is without any direct sort of, media advertising to the population. So we're anticipating, as time goes on, that number to go up even further. We know that already radiology, as Chris has already said, demand versus supply, radiologists are already busy people. And so the use of AI is essential not only for how we acquire the imaging, because it's all low-dose imaging. All of our CT scanners now use AI to reduce the radiation dose. That's one of the key reasons we've been able to even introduce low-dose CT as a national program. But when it comes to us as radiologists interpreting the imaging, there's a lot of manual tasks. For example, identifying the nodules, but then to measure them, to estimate the volume. It's impossible for us as humans to do volumetry and to work out volume doubling time, which is a key component in identifying the trajectory of a nodule's growth. Because once we have one snapshot in time, the baseline image, that's fantastic, but it doesn't tell us what those individual nodules are going to do over time. And that's where the follow-up protocol comes into it to be able to decide whether something is growing, slowly growing, stable, or getting better. And that really then determines what happens next. And so without the use of AI, not only to help us to detect, but also to measure, we wouldn't be able to roll out this program at scale.
I was going to go to Chris, but I'm going to follow up on that for a second. Do you think the AI is there yet to do exactly what you're referring to in the way that you need it?
Absolutely, yes. We're very fortunate that we have a number of tools to choose from. The key thing for us as a radiology practice, no matter who you are as a practice, is finding the appropriate tool that your radiologists are comfortable with, that is accurate enough, that does the essential tasks that we need to detect and to measure and to compare. And then third of all, integrates with your IT system, which I think is probably when we're going to cross over to Chris.
That's a great segue. Chris, how are you thinking about the challenge of integration of AI into existing IT systems as CIO? And what recommendations would you have for others looking at the same path?
Yeah, it's certainly a key challenge, and something that I've really appreciated since I've been working for Perth Rad Clinic is the absolute importance of doctors' workflow and the impact on your cognitive load and making sure that doctors are happy, productive, and not having unnecessary distraction. And so any type of tooling, whether it be AI or beyond, which interrupts that, is certainly not going to work for us, and I'd probably argue any radiologist around the world probably. And so, yeah, key consideration for me and my team is making sure we get that balance right. And, I've got really, really lucky and fortunate, very some capable people in my team, very, very strong from an IT perspective and also a clinical perspective. And so, yeah, we've been working hard for a while to making sure we can evaluate different AI tools and integrate ones into our workflow, which does allow them to measure and get the benefit and really approach the program in the right way. And thank you to the CARPL team. We've been working with CARPL for a little while, working on some different trials and opportunities there. And absolutely, we've got a great level of service there. And obviously, Intelerad played support in that, played a role in that as well. And absolutely got us to a point where we are getting benefit from a particular tool as well as to different others, where it can really allow us now to start to open the taps a little bit more and scan more patients. Integration in that, though, absolutely was is a still difficult piece of work. We're not quite there because make sure that everything flows. But the CARPL group have really worked that through with us and got us to a good spot.
Thank you. And that's a great segue then across to Dr. Sarang. How do you think about the role that CARPL plays in the problem space that we're describing here? And what is the differentiated advantage that CARPL brings to help meet patient outcomes here?
So, first of all, since the program has specific needs and none of the AI are yet ready to give the requirements or the parameters which are required for the program. Just for example, for the baseline, you require a pan-can risk score, which requires a clinical input to calculate the score. And none of the AI right now are doing that. Of course, AI can be very helpful, as Dr. Jones mentioned, to detect it, characterize it, make the volumetry. And but still, there was another requirement for the program that you need to be reporting in a specific structured format. Also, you need to choose top 4 nodules to be reported for the follow-ups. So all those required, there were still the gaps we need to fill in, where CARPL as a platform not just integrates an AI, but also has built up a custom workflow where you can interact with the through our workflow to decide which nodules to be sent for the reporting. Also, automatically calculate the pan-can risk automatically, and that's how we are trying to implement the program and through our custom workflow.
Thank you. Maybe head back over here for a second. When we think about the problem of disadvantage in remote access, you were mentioning that's also a part of your leadership role in the program. How are you thinking about overcoming that problem of distance, especially in Australia? And how can AI help with, I guess, the inevitable shortage of radiologists on the scene in some of these remote communities?
So that's a great question. And I think the lessons we can learn from Australia can be applied to many other parts of the world, the US and Canada, of course, being very large countries. But we now know that being able to take the radiology clinic to the participant in the program is just as valuable in places like the UK, where they put the mobile CT screening truck into the car park of the local supermarket. And that increases the uptake in the program because you're no longer having to go to the hospital, which is a scary place. You can, do your groceries and then have your screening test at the same time. So the general principles, of course, when we think about the tyranny of distance, and Chris knows this very well, I come from Queensland, which actually has the highest proportion of population living in a regional and remote area in Australia. It is not just that it's a few minutes down the road to a CT scanner. You could be driving for a day or longer to get to a place with a CT scanner. What we've decided to do as part of the program is to provide mobile CT screening trucks. And in fact, this is great timing because today is the first day of screening for the mobile CT in Western Australia. Okay, so, it's a federally government-funded program. There will eventually be 5 trucks spending, almost all of the time traveling around different states of Australia, providing remote and rural screening for this program. Now, there will not be a radiologist on the truck. Okay, I'd love to be out there wearing my hat, but I can't. I have to be sitting and reporting in my metropolitan clinic. But because we can use, the power of AI, we're able to triage up immediately, those CT scans that look like they might have a mass or something which, perhaps we need to do something better. We need to have a better quality image. The AI can flag this for us without me or one of my colleagues looking at it straight away. And that solves the problem of what do you do if the truck has already moved on to the next town? No, we'll be able to identify that straight away, flag a problem straight away, and if need be, do a follow-up scan. Perhaps that's the time when we do the contrast CT for staging. We look at that next possible test there and then, same day. And so that AI-driven triage flow is absolutely essential for those areas where radiologists are not on site and the truck won't be there next week either. So that's a really key differentiator for those people who live in the regional and remote areas.
That's an absolutely fascinating use case for AI in the space. We often talk about it in other ways, but the ability to be able to triage automatically while a truck is in a remote community is a fascinating contribution to patient outcomes. That's very cool. Thank you very much. Chris, I might hand over to you. PRC is a very large provider in West Australia. How are you guys thinking about the problem of remote access and remote communities across a very large state, as you said, 4 times the size of Texas? How are you thinking about that problem?
I think for us, unfortunately, is we don't have remote units. It's great to hear there's a federally government-funded opportunity there for rural patients to get that access. I think for us, our clinics are where they are. We are located in metro area. We will have our first regional one, as I mentioned before, in Bunbury. And so certainly would like to hope then that having that extra clinic down in an area which is in the southwest of Western Australia, and there is a fair population down there with limited access to radiology type services, that opening that clinic then will certainly then, it won't be a day's drive to get to that kind of assistance. And previously it might mean going up into Perth or another radiology provider a bit closer to where they live. At least then having a clinic a bit further out my metro area then will allow us to provide that service. I think more holistically in terms of patient outcomes and patient care, it's great that we're playing our part, but also it's great to hear as well that these trucks are visiting these locations around states such as ours, which are very spread out, and also Queensland and the rest of Australia, and providing such a great service.
Thank you. One more question over here. I apologize. I'll come back to you in just a second, Dr. Sarok. We had talked earlier about of a small clinic starting up, wanting to get involved in the National Lung Cancer Screening Program. How should they get started? Any tips you've got for a new clinic who wants to jump on board?
So the first thing I would say is, and this is for anybody who's watching today, there is a wealth of resource available, on the National Lung Cancer Screening Program website. That's available to everybody. It's free to download. It goes through everything from who's eligible through to how to acquire the scans, information for your clinic staff, around, how to answer questions from members of the public who might be interested in participating, all the way through to, as the radiologist, how to actually approach the interpretation of the imaging. So first thing is education. So, find out the information. It does seem a little bit daunting. If you're a radiologist wanting to be involved, there's many online free resources through the Royal Australian and New Zealand College of Radiology website, which I strongly recommend. As well as that, there's integration with, the National Cancer Screening Register, which can seem quite daunting as well. However, there's many ways to get it done, and there's lots of advice available through the people at the screening register. So it's not an overnight process to start, getting involved with this. If you'd like to actually contribute in doing the scans, but perhaps send the images to be reported by another group like PRC or any of the other private providers who can help doing the reporting, that's one way to get involved in helping your local community. And I'd really recommend this, particularly for small groups that may be the only provider in the town that they're in, because otherwise the people in your community won't be able to access the program. So there's definitely ways to do it. But I'd start off by looking at the resources on the National Lung Cancer Screening website.
Thank you. And I promised I'd come back to you, Dr. Sarang, and I will. When we think about a screening program like this, with potentially up to 1 million folks getting screened every year, how does CARPL approach the problem of false positives in this context, optimization, false negatives? How do you approach that problem within CARPL to make sure that we're additive rather than subtractive at the end of the day?
So first of all, it's expected to have false positive in such kind of programs because AI are designed to be more sensitive, because screening programs are more, we don't want to miss out any nodules, but it's okay to have false positive. But that becomes a challenge for a radiologist because a lot of false positive can distract them. So at CARPL, what we have done is we have developed a module where you can manage those nodules, and of course, where you can quickly review the nodules through our platform, decide whether it's not, and delete it from your list of the nodules. So that's one of them. Second is we also provide active feedback to our AI vendors. That look, these are the cases where we are seeing a lot of false positives, where they can quickly iterate their model. Of course, if it's minor update, it can be immediately updated. However, if it requires a major update, the cycle, because it has to go through the regulatory cycle as well. So that will take some time, but we try to fast forward it by giving an active feedback to the AI vendors. So that's the two way we help to reduce and minimize, or rather, I would say, optimize the false positive. There are going to be false positives because AI are more sensitive than more specific.
I just wanted to reiterate the point that there's no such thing as a perfect diagnostic test. And so we hold AI to a pretty high standard, and rightly so, but we need to acknowledge that human performance is not 100% accurate either. And so for many of us clinical radiologists who report a lot of these cases, knowing that we have a really sensitive test available to help us through the AI gives us that sense of reassurance that we're not missing something that needs to be included. And that's definitely worth a lot. It's really important to know that whilst we have some false positives, it has markedly improved over the last 5 years. So if we look at the evidence as the models improve, so does the rate of false positives continues to reduce. And so it's something we accept as, a very positive benefit, particularly when we're getting the reassurance of a very low false negative rate.
Thank you. In the interest of time, I'll start to wrap up here. Chris, I'll throw it over to you for a last question. If you fast forward 5 years at PRC, how will radiologists be using AI on a day-to-day basis?
Yeah, very interesting question, and I think it's there was a kind of an infographic or a meme sent to me a while ago around a talk a few years ago. Radiologists will be obsolete in 5-10 years. AI will take it all, and then it showed a picture then of Teslas and automated cars and self-occupied. No one's going to drive anymore. It's automated cars. And here we are in 2025, and radiology is absolutely obsolete. And there's no self-driving cars, generally in operation around the world. Why that's kind of relevant in my thinking is that in 5 years' time, I would expect any AI tool in the radiology space just be more finely tuned. I think right now we're in a bit of a gold rush period, quite frankly, where there are a lot of vendors and some will survive and some won't. And I think in 5 years that will settle and there will be core key providers which will really then augment a radiologist in their work and become their co-pilot to help them with what they do, increase their satisfaction, also generally make them more efficient and accurate or more assured away in their work. So very much not a replacement piece, but very much I'd like to think there will be then a core set of tools, if you like, which then will be available, tried, tested, and be continually refined and allow us all to provide the best service that we can do.
Thank you. Thank you, Chris. Dr. Sarang, maybe one last question over to you. We're here day 2 of RSNA. CARPL was here last year as well. How have the questions changed since last year?
So we are getting a lot of people are asking now more about monitoring, because I think that is something coming up, and with like European AI Act is now making it mandatory to monitor the AI, and since that module was already developed with us, but this year we are seeing that is being asked more often than before, because that is because of the upcoming regulatory changes, and I think FDA and other regulatory bodies will follow this soon. So I think that's, and also we are also actively working to make it more comprehensive monitoring for radiologists.
Thank you. And lastly, Dr. Jones, what advice would you have to your colleagues around the world when other jurisdictions are going to look at similar screening programs and the like? What advice do you have after 4 months on the ground that might help them?
I would say that over the last 5 to 10 years, the evidence for screening, particularly for lung cancer screening, has grown to the point where it's no longer a should we do it, it's how can we make it happen. Certainly don't try to reinvent the wheel. There's so many great protocols already out there. So pick the best of all the different protocols that suit you and your population. I would certainly focus on vulnerable population groups. Again, we have lots of evidence about who they are, and to make sure that they are front and center in all of the planning that you have, because the last thing we want is for screening programs to widen the equity gap between those groups and the mainstream. But I will also say it's probably the most satisfying thing I do in my clinical day, knowing that I am contributing in a meaningful way to the outcomes of, potentially hundreds of thousands of Australians every year. So if you haven't already gotten on board, please do. It's a great activity to do. And I'm looking forward to seeing the first results coming out in the next year or two about how it's affecting our patients.
That's incredible. Thank you. And I think a great note to end on there. So thank you very much to our amazing panel. Thank you. Thanks to anyone watching.